Hello, greeting everyone. My name is Dr. Suppachok.
My name is Sirawat Srichatrapimuk. We are in an infection control team of Ramadhibodi Chakri Naruebodindra Hospital. So in the next 30 minutes, we would like to share our experience on infection control in response to the recent Thailand COVID-19 outbreak. We would like to first introduce our hospital. Ramadhibodi Chakri Naruebodindra Hospital locates in Samut Prakan province near Suvarnabhumi Airport. It is a relatively new hospital that contains around 120 beds and 20 ICU beds at the moment. It serves to manage and care suspected and confirmed COVID-19 patients, including those diagnosed at our sister hospital, Ramadhibodi Hospital. Around 150 confirmed COVID-19 patients have been admitted in this hospital since March of this year. So as you have already heard from Dr. Kamthorn, principles of hospital infection control for COVID-19 basically consist of the early diagnosis of cases and the early isolation to prevent spreading of to the other people. So the early detection can be achieved by the intense screening and the early laboratory confirmation. This screening should be done both in the patients and close contacts, as well as the hospital personnel. As for the isolation, the suspected or confirmed COVID-19 patients should be put on the droplet and contact precaution. Unless there is an aerosol generating procedure performed, the isolation should be changed into the airborne plus contact precaution. The other components that to make a successful isolation include the facilities, including the isolation area, the clinic, the ward, the quarantine ward, and the cohort ward for the confirmed cases. The equipment, including the personal protective equipment or PPE, the hand hygiene, the environment cleaning and waste management system. And also to put together, we have to design the flow or the system for the patient and staff to communicate all this into the personnel and have the practice. So in a sense, this can be summarized into four main aspects: the area, the equipment, the flow, and also the people. So I will first go over the facility, which are the area and equipment. The hospital section caring for the patients consists of the two buildings linked together: the main hospital building and the G building, which is initially designed to be a premium wing but had not yet been opened. In March, when the COVID-19 cases in Thailand surged, the hospital committee decided to designate this G wing for caring suspected and confirmed COVID-19 patients to minimize exposure to other patients as well as healthcare workers. So we use first and second floor of this building for the acute respiratory tract infection clinic and the fourth to 7th floor for the COVID-19 cohort ward. The acute respiratory infection clinic is designed for outpatients who present with symptoms of acute respiratory tract infection. Attempts is made to keep distance between patients and also to separate the patient under investigation from other low-risk patients. The emergency department also set a separate room for patients with suspected respiratory tract infection, so that the care of such patients do not cause the spread of the infection to the other people or other patients. The cohort ward consists of the separate rooms for confirmed COVID-19 patients. We do not have a negative pressure ward at that time, so the hospital team modified the airflow, and also in addition to the general fixation of equipment and instruments, we modified the hospital team modified the airflow by occluding certain air ducts and use the exhaust fan, creating a pressure gradient that makes the airflow direction from the next station to the hallway. and from the hallway to the patient room. So this is a test that we use to verify the airflow direction. So as you can see, the smoke was sucked into the side of the patient's room. The hospital IT team also set up the telemedicine system with camera, computer, and TV monitor to aid communication between staffs and patients and to minimize the unnecessary exposure to the patients. We would visit the patients if we are not sure about the patient's condition. If the patient is quite well, we could communicate with the patient just by over the system.
Let us see to the cohort ward. This is the inside of the room. We used as the cohort ward isolation room. We modified the single room for the patients for the isolation room as well. As you can see on the right side of the picture is actually in the front of this picture. We show that we set the telemedicine and the TV with video camera for the video call from the nurse station, as we told the previous slide as well. If we look about these little tables, actually we dedicated the table for the food drop area for sending some foods or drugs in the certain times. For example, in the morning, noon, evening, and before the sleep, to decrease the exposure to the healthcare provider. And in the right side, we also have the patient's equipment area for some deploy some medical equipment as well. And here this is the demonstrations of the telemedicine used in the cohort isolation room. This nurse from the nurse stations can contact to the patients via the video call that the IT hospital team setting up, and can take a look to the patients to observe the clinical manifestations such as the respiratory rate and to ask the symptoms of the patients. But to be know that we use this system to just the screening tools. If the patients have to develop the deterioration symptoms, the doctor and the nurse have to put the PPE to fully examinations and evaluation of the patient as well. And here in the toilet, we place the infectious waste test for the possible contaminated waste such as the user's clothes or another infectious waste as well. When the healthcare provider finished their work test in cohort isolation room, the healthcare provider should remove the PPE outside the room. We provide the bin and the alcohol hand rub gels and the instruction manual posted outside in the doors. And for the healthcare provider who are not sure about how to removing the PPE properly, we also use the buddy model. For example, use another healthcare provider who didn't coming inside but observe when the healthcare provider wearing off the PPE. So it's helpful to reduce the contaminations after the removing PPE. And as we know that about the 10 to 20% of the COVID-19 patients may develop pneumonia and to progress into the severe pneumonia in some cases. So we decided to prepare the ICU ward at the main building on the fourth floor of the main building with the AIIR capabilities. At that time, we have the 10-bed single AIIR ICU room for the patients. We're preparing in case of the clinical complications such as respiratory deteriorations or any signs of the potential to progress to respiratory failure. So we decided to move the patients before they got ill in the cohort ward. And we also set up the IC protocol as well. As you will see that we put the instruction manual for donning and doffing the PPE, set the infectious bin chairs in the ante room. And on the right side of the picture, you see that the doctor will set the parameter before we move the patient inside the room. And the IT team also created the video camera system to provide the telemedicine for monitoring the parametering from the medical device such as the ventilatory setting, vital signs, ECGs, pulse oximetries, and other things from the record for monitoring the patients and reducing the healthcare provider exposure to the patients as well.
The equipment has to be prepared So we use dedicated devices such as the automated blood pressure measurement device and a pulse oximetry and thermometer for each patient. And after instructing the patients, they can use these devices to measure their vital signs, and we then ask for the figures from the patients by using the phone or the telemedicine system. And these methods help minimize the exposure to our staff. And the other equipment has to be prepared as well, including those used in the ICU, and also the personal protective equipment or PPE. Adequate PPE stockpiles is essential, and we have to ensure the adequacy and correct use of the PPE. And reuse of the certain PPEs has also been applied. For example, the N95 mask or the hood that we use for the PAPR or positive air purifying respirator. So next section is about the flow or system. So I recommend you to think ahead to set up the flow or protocol for processes dealing with the COVID-19 patients. We got the reference from a national guideline, but there are some details that were specific to each hospital and had to be discussed in the team and set up. So first thing first is to set a screening protocol for all patients.
Okay, so at first you will see that the hospital we have the many entrance for in the first and the second floor. Moreover, we close the unnecessary entrance to ensure that all of the patients will receive the screening area. As we told that screening all the patients intensively, we increase the voice announcement and emphasize hand hygiene with alcohol hand rub before entrance into the hospital, and emphasize about the surgical mask use to all of the patients. And this is a screening protocol. We use like a two-step for screening because we cannot use the overall protocol to screening all the patients because of burdens of the questionnaires. So we use the questions at that time we use about the risk area, such as from the outside the countries or from abroad, from the patients who entry to the risk areas such as the bar, like in the boxing area, boxing gyms, from the previous news in that time. And after that, if we have such a risk area, so we move on to another questions about the respiratory tract symptoms as well. So if the patient have all of the risk, we define as the PUI, patients under investigation, and will extract this patient to another flow for the PUI patients. So when the screen that the patients may have the respiratory tract symptoms, whether or not have the risky area or PUI, we will move the patients into the acute respiratory tract infections clinic that's set in the second floor of the G building wings.
And after the patients has been examined by the doctors, the COVID-19 confirmed or the suspected cases would be admitted to the hospital. So we have 3 different types of ward caring for patients with different severity. So patient care processes are also different among these 3 wards. For example, the ICU patients needs close monitoring and sometimes more healthcare workers protection, and the criteria has been set for patients to admit to each ward and to transfer between these 3 wards, and also to discharge from the hospital. I think the criteria will be covered by another section.
So this is the cohort ward. At the first, we open up the cohort ward. We including ID doctors, IC nurse, cooperated with the other segments such as IPD nurses, the deputy director of the facility management system, and the deputy director of the hospital IT system. We all together set up to build the most proper cohort ward at that time. At first, we draw the line for reminding us which floor does the patients move in and move out. So we move the line to remind us where is the risk area, maybe the potential to contaminations, which is a clear zone. So it might be useful for to track and flow the patients. And after that, about the logistics, the patient transfer, we created the zoning of the patient and designated some of the elevators for use only the patients And when we transfer the patient from the other to the other places, we do the blockage, the route for the patients when they move in and move out. So decreasing the risk of the transmission to the other patient as well. So about the cleaning, we set the protocol for cleaning. It depends on the activities of the cleaning, and the PPEs depends on the activity as well, such as if the activity may have the risk for the aerosol generating procedure, we use the full PPE. And we training the cleaner both PPE, doffing and donning, and the method in the cleaning before they got into the work in the cohort ward. And about the waste management, as we know that in the COVID-19 pandemic era, the infectious waste product increasing dramatically. So we increase the infectious waste bin size and also increase the cycles transferring the waste into the infected waste area.
And the protocol for the correct or appropriate personal protective equipment use was also set up, and this was discussed and set according to the type of the personnel and also the activities that they do to the patients. The poster indicating the steps for donning and doffing the PPE were also made widely available in the area caring for the COVID-19 patients. Other supportive processes also need to be set up. For any new area, the fire safety protocol has to be created. For example, the location of the emergency exits and function of each personnel in case of the fire events. And also the several disinfecting agents are classified as hazardous material. The proper storage, quality check, and the application of such agents has to be ensured. For example, alcohol is flammable, and specific condition and keeping place must be assigned. The security is another issue, so we have prepared our security officers in case of the violent COVID-19 patients. These instruments help to lock the aggressive patients while keeping distance to the officers. And the sticker is used as a kind of like a visa for the healthcare workers who are responsible for suspected and confirmed cases to access the G-Wing. We also have a one-day sticker for visitors in such an area. And lastly, it's the people who operate this process that matter. Thus, it is essential to communicate all these protocols and to set up the drill of important processes. For example, this is a picture of the drill of the operation of the COVID-19 cases. And we get a lot from the practice and drill like this. And we also got feedback from the frontline workers and adjust the process accordingly. So the challenge of the COVID-19 is that you have to keep yourself up to date regarding the situation and also the information from the studies and to apply that in the practice. So we hope you get some points from this presentation. And lastly, we would like to thank all staff of the hospital. We greatly appreciate their devotion to the work during the COVID-19 outbreak. And we also would like to thank staff from our sister hospital, Ramadhibodi Hospital, for their help. And thank you for your attention.